Hello everyone, let's discuss the topic hypermetropia, which is also known as hyperopia, farsightedness or longsightedness. It is a refractive error of eye in which the parallel rays of light coming from infinity are focused behind the retina with accommodation being at rest. Etiologies include number 1 axial, which is most common. 1 shortening of the eyeball results in 3 diopter of hypermetropia. At birth, plus 2.5 to 3 diopter of hypermetropia is physiologically present. It can be pathologically seen in inflammatory masses, any edema, coloboma, microphthalmos, any tumor. Number 2 etiology is curvatural, which is in which there is flattening of cornea or lens or both. 1 increase in radius of curvature results in 6 diopter of hypermetropia, and this never exceeds 6 diameter hypermetropia physiologically. It may also be found in congenital conditions like cornea plana and may also result from trauma or any disease process. Number 3 is index, which is in which the changes there is change in refractive error of lens, and it is physiologically seen in old age. Pathologically, it can also be seen in diabetic individuals. Number 4 etiology is positional, which is in which there is posteriorly placed crystalline lens and occurs as a congenital anomaly or may result from trauma or disease process. There might be absence of lens, which is seen in aphakia. Clinical types include number 1 simple hypermetropia, which is the commonest form, and it may also be hereditary. Number 2 is pathological hypermetropia, which may be due to congenital or acquired process. It may be senile or acquired hypermetropia, which includes curvature and index hypermetropia, or it might also be due to positional hypermetropia, or it might also be a case of aphakia. Now, functional hypermetropia, it results from paralysis of accommodation and is seen in patients with third nerve palsy and internal ophthalmoplegia. Parallel rays of light focus behind the retina, so diffusion circles are producing blurred and indistinct images. The retina, as the eyeball is smaller, so the retina is nearer to the nodal point of eye, and there is formation of clear image only by the lens which has converging power. Now there are various nomenclatures of hypermetropia. Number 1 is total hypermetropia, which is an addition of latent and manifest hypermetropia. What is total hypermetropia? It is a total amount of refractive error which is manifested after complete cycloplegia with atropine, and it is divided into latent and manifest hypermetropia. Latent hypermetropia, it is corrected by inherent tone of the ciliary muscles and is usually about 1 diopter. Latent hypermetropia is high in children and decreases with age, and it is revealed after abolishing the cycloplegic action with atropine. Number 2, manifest hypermetropia, which is remaining part of total hypermetropia and is corrected by accommodative effort. It is measured by adding the strongest additional lens. Now, manifest hypermetropia is itself divided into facultative and absolute hypermetropia. Facultative hypermetropia is that which is corrected by the patient's accommodative correction, and the residual part is known as absolute hypermetropia, for which the lenses have to be used. Now, there is normal age variation of hypermetropia. Like at birth, I told you that there is plus 2 to plus 3 diopter of hypermetropia, which is physiological. So it slightly increase. The eye gets emmetropic by the age of 6 to 7 years. Till then, the normal refractive error is hypermetropic, and it is completely physiological. In old age, there is again a tendency to gain hypermetropia, which is after 50 years. It is due to the tone of ciliary muscles which is decreased, and as the tone of ciliary muscles is decreased, the accommodative part decreases. Now the symptoms of hypermetropia depend on the basis of degree of refractive error. Principal symptom is blurring of vision for the close work, but it is not the only symptom. The patient of hypermetropia may also be asymptomatic as there are small refractive errors which produce no symptoms, and it is corrected just by accommodation. There is no complaint which patient comes with. So no correction is needed at this stage. Now there may be asthenopic symptoms in which the refractive error is fully corrected by the accommodative effort, thus the vision is normal. Like if you take the visual acuity in such patients who are having asthenopic symptoms, then the vision might come 6/6, but the hypermetropia may also be present. So what are asthenopic symptoms? They are symptoms like tiredness, frontal or frontotemporal headache, watering, and there may be mild photophobia. Now there may be defective vision with asthenopia, and it is in these cases manifesting with defective vision with accommodation with asthenopic symptoms. The error is not corrected by accommodation, so the defective vision is mostly for near work, and the asthenopic symptoms increase when the patient does the near work. It is usually found in conditions in which the refractive error is more than 4 diopter. Now only defective vision, refractive error is more than 4 diopters, and as adults usually do not accommodate, they present with defective vision only in cases of hypermetropia. Now signs, number 1, visual acuity. This depends on the basis of the amount of refractive error. Like the patient might see 6/6 vision, but in some cases the patient might also complain of decreased vision. Now eyeball, it might be small or normal in size. Number 3, you can do cover test for accommodative effort. As if the accommodative effort is high, then it may also result in esotropia, which is known as accommodative esotropia. Now eyelids, the patient might get blepharitis, styl or chalazion due to repeated rubbing of the eye. Cornea, it may be smaller than the normal, and there might be cornea plana. AC is usually shallow. There are chances of glaucoma also, and patients of hypermetropia are prone to develop attack of narrow angle glaucoma. Lens may be dislocated backwards. On A-scan ultrasonography, we might get short axial length. Now fundus signs, it includes disc changes, which is known as pseudopapillitis, as there are blurred disc margins with hyperemic disc resembling to papillitis, but it is not papillitis, it is pseudopapillitis, and it has to be differentiated from papillitis. With the other signs, like in papillitis, pain is also present, macular fan may or may not be present, but these all signs are absent in cases of pseudopapillitis. Now in macula, there are large positive angle alpha, blood vessels may be accentuated, and there might be undue tortuosity. The background of fundus may give short silk appearance. Now the severity of hypermetropia can be graded as low, moderate or high. In low, the refractive error is up to 2 diopter. Moderate refractive error from plus 2.25 to plus 5 diopter, and high hypermetropia is more than plus 5 refractive error. High refractive error or high hypermetropia, which is more than plus 5 diopter, is usually till plus 6 or plus 7, and is rarely beyond that, because there is 2 mm shortening in these cases. Now the complications include recurrent cystitis, blepharitis, chalasia, accommodative convergent squint. There may be anisometropic amblyopia or strabismus resulting from the uncorrected bilateral high hypermetropia. There may be predisposition to develop narrow angle glaucomas. Now the basis of treatment is that the basis of treatment is the convex or plus glasses should be used, and no treatment is needed if the error is very small or the patient is asymptomatic. Now the refractive error which is seen in hypermetropia can be tested by two methods. Number one, there might be we can do fogging, and number two, we can do cycloplegic refraction. Now now in young children less than 6 years, usually we give the same correction which comes on the retinoscopy. As much correction is usually not needed, but these patients are required for the follow-up in every 6 months, because till 6 months there is physiological hypermetropia also. Usually these patients do not need correction, but if the patient is a child who is not able to see the blackboard properly, then we can prescribe him the glasses. In adults, usually the hypermetropia is manifest hypermetropia, and it is usually absolute because there the CRD tone decreases, so there is not much accommodation. Hence, it cannot be corrected by accommodation. So in these patients, hypermetropia must be corrected, but it must be differentiated between physiological and pathological hypermetropia, because in physiological hypermetropia just the spectacle correction is needed, but in cases of pathological hypermetropia, the underlying pathology like any tumor or any inflammatory process or edema, they must be corrected along with it, otherwise there will not be any use. Now the mode of treatment are three treatments. Number one is spectacle treatment, which is the most common, and in these cases we prescribe the convex lenses, which are plus lenses. Number two, there are contact lens treatments, and number three, there are surgical treatments. Now surgical treatments are various treatments like PRK, we can do LASIK, we can do LASIK, we can do femtolasic, we can do conductive keratoplasty, laser thermatic keratoplasty, epikeratophakia, epikeratoplasty, and refractive lens exchange based on the procedure required. Thank you.